See, before going into the real problems, we should know about the ocular movements. There are two types of ocular movements. That's one is the monocular movements and then the binocular movements. The monocular movements are otherwise known as duction movements. It's abduction, adduction, supraduction or elevation, infraduction or depression, then encycloduction, excycloduction. And then the binocular movements are version movements and vergence movements. And coming to versions, you have 6 cardinal positions of gaze. They are the dextroversion, levoversion, then dextro elevation, levo elevation, dextro depression, and levo depression. And these cardinal positions are brought about by the actions of the yoke muscles. The vergence movements are eye movements in which both eyes move in the same in the opposite directions. They are the convergence, divergence, and then excyclo and encyclovergence. And I would like to discuss about these cardinal points once more. There are 6 cardinal positions of gaze. In addition to that, the diagnostic positions, 3 more are there. All these things combined together is these 9 diagnostic positions of the gaze, which is shown in this picture. So when we examine a patient, we have to see the 9 positions. And one word about the assessment of ocular movements. First, when a patient comes to you in the strabismus examination, we have to first examine the binocular movements. When both eyes are open, with a small pen light, first in the primary position and then moves in different directions in the form of an H. It is known as a broad H test. In the direction of H, you test the primary position, dextro elevation, dextroversion, levoversion, then levo elevation, levo depression, dextro elevation, dextro depression, and then direct elevation and direct depression. And after doing all these things, if there is any limitation of movement, then you have to do the uniocular movements. When testing uniocular movement, one eye has to be closed and each eye has to be examined separately. And if there is a limitation of movement or overaction of the movement, it has to be graded. And just like this, as shown in this diagrammatic representation, it has to be graded on a scale from -1 to -4 and then +1 to +4. If you denote 0, that means the ocular movements are normal or full. After that, we have to examine convergence. You can use an object about 40 centimeters in front of the eye, which is brought forwards towards the eyes, and look for the point of when the eye deviates outwards or diplopia. Or you can use the RIF. If there is a convergence insufficiency, it can produce to asthenotic symptoms, exodeviation, etc. And torsion has to be examined by the double Maddox rod test as shown in this video. And torsion can also be examined by looking at the fundus by indirect ophthalmoscopy or fundus photograph by looking at the position of the fovea in relation to the optic disc. And the documentation of ocular movements, I would like to say a word about this. There are different types of ocular movement documentation. This is a slide I took from the one of the famous lectures of Professor Pradeep Sharma. This is denoted in this picture, but for simplification, I have made it again here. See, the most popular type of noting the ocular movements is the H pattern, as you see here. In the medially, there is medial rectus of either eye, inferior oblique in upper inner quadrant, superior oblique, lower inner quadrant, inferior rectus, lower outer quadrant, and superior rectus, upper outer quadrant, like that. And then another form of notation is the diagonal form, like this. And another form, which is very popular in the America, is like this. Here in this picture, you can actually give complete strabismus examination. The updrift, downdrift, the measurement, everything can be denoted in this picture. And any overaction is denoted by plus signs and underaction by the minus signs. And now I come to the specific clinical conditions. The most important ocular motility problem, most common, is the pattern deviation, where the angle of the deviation will be different in up gaze and down gaze. For example, look at this video. This is a child presenting with a exo deviation in the primary position. It's about 15% exo in the primary position, but when the patient looks up, the deviation is increased and there is a upshoot of the eye. You can see that now. You can see the left eye both eyes are showing upshoot in the adducted position. So this is a pattern deviation, V pattern exotropia, and the movements can be notation is like this. There is a the updrift can be drawn like this. There is a +3 overaction of both inferior oblique, and the angle of deviation is 15 prism diopters for primary position, 30 prism diopters, and then since this is a V pattern, you can put two diagonal lines like this and notate the V pattern. And now coming to the dissociated vertical divergence, that is again another motility problem where there is spontaneous upturning of the dissociated eye. When both eyes are open, there may not be any deviation, but when you cover one eye, that eye goes upwards. You just see this video, you can see the upward movement. When you under the cover, the eye moves upwards and then comes downwards to take a fixation. This in primary position, both eyes will be straight, but when you cover the eye, you can see that, appreciate that. That's the dissociated vertical divergence. And then we'll come to upshoots and downshoots. You can look at this video. Upshoots and downshoots are common with the Duane's retraction syndrome. In this video, you can see there is adduction and abduction deficit plus upshoot and downshoot, which is occurring in the same eye. Now you can see there is a downshoot and sometimes upshoot. Both upshoots and downshoot occurring in the same eye is always a Duane's retraction syndrome. This is a left DRS. The upshoots and downshoots are because of the mechanical reason of co-contraction of lateral rectus and medial rectus, which gives rise to a slippage of the muscle on the globe. So this is again another person with the primary position. There is no deviation. On adduction, there is downshoot of either eye, both eyes downshoot. This is again a Duane's retraction syndrome. This can be managed by the surgery of Y splitting with recession. This is the pre-op. You can see the downshoot. It can be easily corrected by the Y splitting. These are the post-op pictures. Y splitting of the lateral rectus will give rise to correction of the downshoots and upshoots. And here is again another motility problem. Primary gaze is normal and there is defective elevation. This is a congenital problem and only defective elevation in the adducted position. This is a Brown syndrome. This is also a common motility problem. Again, I'll come to another acquired type of motility problem. The child presents with a sudden onset of head tilt and defective elevation, and this occurs all on a sudden, and most probably this is an acquired Brown. And the treatment of acquired Brown is conservative. You have to do a scanning, imaging is needed, look for any oblique problems, and if there is no fractures or any tumors or anything, you can just give anti-inflammatory, and we can give an anti-inflammatory steroid injection into the trochlea, and this acquired Brown syndrome is amenable to treatment. With this, I am ending my talk. Thank you very much.